The World Trade Center Health Program leadership is committed to the support and integration of lifestyle medicine services for the benefit of our enrollees. The program's 2022 Lifestyle R21 research solicitation is designed to identify and support research that improves understandings of the interventions that have been tried to date in World Trade Center Health Program populations, the results and outcomes achieved, and the impact on World Trade Center related disease trajectories. Dr. Arcan is currently a registered dietitian and an associate professor in the Department of Family Medicine and Population Health at Virginia Commonwealth University. She obtained her doctoral degree from the University of Minnesota School of Public Health, Department of Food Science and Nutrition. Dr. Arcan's research is focused on obesity, excessive weight gain, and chronic disease prevention through the promotion of healthy eating and physical activity behaviors, especially among diverse and vulnerable populations living in a variety of community settings. She has also studied the effects of nutrition interventions on systemic inflammation, PTSD, and cognitive decline. Previously faculty at Stony Brook University, she will be presenting her work on the World Trade Center nutrition study today. Thank you so much for joining us, Dr. Arcan. The floor is yours.
And thank you very much. Let me share the screen. I hope I'm successful this time. Can you see that or not?
Yes, we can see it. It's just in the speaker notes.
I have to change that again.
Yes, I think it's just the display settings at the top.
Yeah, I know. I have to, 1 second. It's, oops. It was accessible before, right?
Yes, it was.
Am I sharing anything now or not?
Yes, you are sharing your screen.
But not the,
Yes, not the slideshow yet. Okay,
What?
and then we see the speaker notes again.
the speaker notes again. 1 second. Which one to?
Right, so if you just go,
Yeah. Oh, maybe here.
yep, right there. Awesome. You're all
Alright.
set, Dr. Arcan.
Okay, when you need it the most, it doesn't work. So thank you very much for the introduction, and thank you for inviting me to present in front of you today and for attending my presentation. Let me just pull some of these windows on the side. Okay, good. So in 2020, in December, we received funding from CDC NIOSH for 1 year to conduct an intervention in the World Trade Center health program in Stony Brook Medicine. So basically what we wanted to do, it was a year long, and what we wanted to do is to conduct an intervention which was a feasibility study, and it was a pilot intervention. It was focusing on nutrition, and the goal was to reduce body weight and systemic inflammation among the World Trade Center responders. Just want to make sure that I can see some of you because I don't see anybody right now, and it's not good, but it's okay. Then I'll go on with my presentation, and then I cannot see anyone because I don't know if anyone has a question or is something in the chat, but I'll go on with the presentation. So, here I'm pointing out to what do you see here now? I'm pointing out to the World Trade Center, the 2 clinics that we have, and that's where we conducted the intervention. So. Can you see that now?
Yes, we can see the
Okay.
next slide.
Before I continue with describing the intervention, I just want to give a little bit of a background on the disorders or the health issues that we are addressing. 20 years after the 9/11 attacks, the rescue workers and other responders have continued to have a lot of physical and other multiple comorbidities, including mental health issues. And one of the more prevalent one is post-traumatic stress disorder. And a fifth of the responders who actually help with cleanup, they develop PTSD, and half of them still suffer from those issues. But they have other physical, health issues, and a third of the responders have at least 3 of the metabolic syndrome components, primarily abdominal obesity and hypertension. Now, from studies that have been done since then, and a lot of them are from the World Trade Center health programs, is they found a connection between exposure to a particular matter and development or association, at least, with metabolic syndrome and cardiovascular risk. So what we know is there are shared immune inflammatory pathways that link metabolic syndrome, obesity, and mental health disorders and PTSD in particular. So there is a low-grade systemic inflammation that is the underlying mechanism that connects the two. So a lot of lifestyle or healthy lifestyle and anti-inflammatory diets have been actually tested, and they've showed that they protect against metabolic and oxidative milieu of both mental and physical conditions. And the Mediterranean dietary pattern has really extensively been studied, primarily for cardiovascular risk prevention, but also for cancer. So it's supported by American Heart Association and others as the recommended diet to reduce inflammation. So what we decided to do is to test this dietary Mediterranean dietary pattern through a randomized controlled trial, which was a feasibility study, was a small study to see how the responders or the participants would actually respond, and see if there was even feasible to do such a study, or for them to change their dietary patterns, having all these issues. So that was the goal of starting this program, because of the multiple comorbidities that they have. So what we did, we designed a randomized controlled trial with half the participants in the Mediterranean dietary pattern, and I'll describe more. And the other half, for ethical reasons, we wanted to have an nutrition counseling component, which was usual care. So keep that in mind when we're looking at the results, because it's a small study and both arms have some intervention. One of them is what we intend to do, and the other one was a usual care. So what our primary aims was to develop and assess the feasibility of this program on the participants. And it was primarily nutrition, but it has a physical activity component or tips, because we wanted also to provide some of that. And our secondary aims was to assess the differences, the pre and post, but also differences between the two groups. Of course, in spite of the small sample size, but we wanted to see if we would decrease any of those measures that we were intervening upon. So we included members who had BMI between, they were overweight and obese categories, so BMI 27 to 40. The age was middle age participants, and those that had PTSD. Now, the cutoff for PTSD, the score, the PCL-5 score is 44. But the reason that became 40 afterwards is because of recruitment issues. We wanted to include PTSD patients, but the reason we were able to go down to 40, we recruited some participants who had been diagnosed previously with PTSD. And maybe in the last measure, it was not 44, it was 40 and above. So we made a little leeway there towards the end. So, and also willingness to participate really and be measured and have their blood drawn. That was the initial inclusion criteria. The exclusion criteria was well, they had to have a Montreal cognitive assessment, so mental decline less than 22. And if they had a malignant cancer, specifically GI cancer that they were not able to eat freely, that was an issue. So we excluded those. And if they had a surgical weight loss, that was bariatric surgery, that was a problem too. So, or if they had any nutrition counseling, either at the health program, the World Trade Center, or somewhere else. And of course, unwillingness or lack of ability to follow the recommended diet or physical activity if they had some kind of an impairment. So we included those. Then we wanted to have English speakers because of, and almost all of them are English speakers. And of course, most of the intervention, 95%, was through text messages and technology, using technology, which was a good thing. And I'll describe it to you. Well, the people had to and willing and able to use the technology. So I'm going to go over the timeline of the study, which it worked perfectly for us for what we wanted to do. It was 1 year. We received the funding in December. Now, we had already got IRB approval and developed all the materials because we wanted to do some kind of an intervention. We wanted to offer that to our members, and we wanted to do a study. So all that was done before. So what was left to do is basically recruitment, measurement, intervention, and post-intervention and 3-month follow-up. So our baseline, we measured a lot of things, and I'll go over them. But so, you know, mine here is the holidays, right? And people eat freely. So what we wanted to do is measure some of the psychosocial, like through surveys, knowledge, self-efficacy, social support, etc., through Qualtrics surveys. And we send them in batches because we didn't know what to expect with the type of the population having also the PTSD. So we didn't want to overwhelm them. And so we measured their biomarkers after the holidays. That was the baseline. And then, of course, we randomized, and then we had a 10-week intervention. And then right after that, we had the same measurements at post and then a 3-month follow-up. So we did blood draws. There was an app to measure daily intake, feedback, anthropometrics, and of course, the surveys. So this is a flowchart of our recruitment and retention. And initially, we recruited in 3 different ways. From medical records, because the dietitians of the study, there were also staff and dietitians at the World Trade Center Health Program. So they had access, and we looked at the last year eligibility criteria based on the initial criteria that we had set up. And then after that, we contacted the members and asked them, to see if they're eligible from the additional criteria. So we lost a few people there, but then the majority of people that they were lost, it was those who were eligible overall, but then only 71 of them agreed to be consented. And some of the issues, well, it was either no response or, when they heard about the biomarkers, they were not interested. But remember, it was right in the middle of the pandemic. And it was basically people were apprehensive to just, I think, to do anything or, be part of an intervention and have to go to the clinic, etc. So we collected baseline data on 71, but then only 62 were randomized at the end and included in the study, 31 and 31. And then almost all of them actually went through the 10 weeks intervention, and 58, about 93%, completed the post-intervention measurements, all of them. And the reason was The reasons were very similar. Either they got very seriously ill or moved and maybe lost interest a little bit. So, and then after 3 months, which was in the middle of the summer, we had 46 participants complete all the follow-up measurements. So when they completed all of them. So 74% retention. And a lot of them also, because of the summer, moved and they went on vacation. Some of them moved to Florida and other places. And from what I remember. So I wanted to describe very, very quickly, just to mention what the intervention was about and the messages that were developed. And I'm not going to go through each one of them, but as you can see here, it was about introduction to Mediterranean diet, the importance of it, how to live healthy in order to lose weight, not lose weight to be healthy, reading labels, packaging labels, and how to prepare, how to save, eating on a budget. That was very important also for many people. Introducing to fats and inflammation, eating vegetables, fruits, the rainbow, the importance of carbs and whole grains actually, and having a balanced meal. Importance of the plant-based diets for inflammation, and tips and everything for a healthy lifestyle. Of course, in every session, these were weekly messages, and in every session, there was also a physical activity tip. I wanted to tell you how the intervention was delivered, and we had a website that had all these tips that I mentioned before. There were, I know you cannot see that, but there were recipes. There was a video at the end of the week, basically for each week. There was 15-20 minute video, and then at the end there was a teach back question in order to see that the participants were actually watching the videos. Very simple questions. And then 3 times a week there was text messages to reminders or reinforce the message of the week, the health message of the week. Initially, we planned for 2 in-person cooking demos and experiential cooking, but because of COVID, we did that remotely. And this is our dish that our dietitians prepared. So it was really delicious, but we did only one, and some participants observed through Zoom. And also there was 3 nutrition counseling sessions. The one was the initial one, the baseline. Then there was another one when we, during the intervention, and then at follow-up also, and at 3 months follow-up, that was for the measurements. So there were 3 counseling sessions. So we measured a lot of things. So at baseline, at post-intervention, like I mentioned, in a 3 months follow-up, there was a psychosocial questions, there was self-report, and also the dietary intake. We thought we should collect them through different means. Again, because we didn't expect which measure and which tool would actually work well with this population. So of course, the Mediterranean diet score has been validated numerous times, and it's a very easy one with having 14 food groups, yes, no. And then of course, the dietary screener questionnaire is validated, and it's an NCI related. And then we actually had chronometer, because the chronometer was an app. It has been used in research before, and it allows, you download it on your smartphone, and then it allows for daily intake measurements. So we asked them to record their daily intake as it happens for a week. So, and then physical activity, we gave them Fitbit, and we allow them to keep them as incentive. And so we asked them at least to put it on, have it on for about a week. And we used about 4 days of good data. And then it was the anthropometrics that they were objectively measured. Again, PTSD symptoms, these were sent through, again, links through Qualtrics, links to their phone. and then they could complete it either on their phone or online. And we had them come over and collect a lot of biomarkers. I'm going to present some of them today because of the time limit. And then also we measured 10 cytokines to see if there's any changes because of the anti-inflammatory diet, etc. So I'm going to have about 8 tables here to go over some of the biomarkers, and then we'll talk a little bit about the post-intervention, more information about the study. So we see the characteristics of the participants match all the World Trade Center responders that you all are aware about. The majority, a little bit, there are Caucasians, and a lot of them were unknown. They marked that. And majority of them are male, and the average age, of course, we set the range. And they were quite educated, had some college or 4-year degree and more. So here we have the anthropometrics. We measured waist circumference because that's very much associated more even than BMI with cardiovascular risk and other health issues. So the normal range is for men to have a waist circumference of 40 and below, 40 inches, and for women 35 inches and lower than 35 inches. At baseline here, and all the tables look the same as far as the setup. So we have the baseline, and then I put down the difference from baseline, and that's median, and the body mass index difference from post-intervention to baseline, and then 3-month follow-up from baseline. So we see that overall we have a decrease of 1.5 inches, and then more decrease. And then we also see that although the waist circumference, there's no difference, which is a good thing between the two groups, we have a larger decrease with intervention versus the control. Of course, it's not significant, and we have to consider also the sample size as well. But both nutrition intervention overall helped. For BMI, we see the same pattern, I should say. But in this case, for whatever reason, they were significant from under control. There were significant differences at baseline. At post and 3-month follow-up. But overall, there was a decline. The Mediterranean diet score is very interesting. The higher the score, the more compliance, it shows more compliance to the Mediterranean dietary pattern. So more fruits and vegetables, more anti-inflammatory foods, etc. So at baseline, the score was 6, which it was quite low. But that's how the Western diets are in general. But what we see improvement for the total sample of 4. So they're getting much closer to the upper range here. And then at 3 months, they continue having a little less, but adherence, I should say, to the Mediterranean diet. For both intervention and control, we have significance, and we see increase in the Mediterranean diet score, which this was very, very encouraging. So as far as the PTSD symptoms that they were measured through PCL5, and basically it was at 52, it was at baseline. We recruited those who had 40 and above, so it was quite high here. But we see a very, I would say large, maybe not total clinically large, but it's encouraging to see a decrease in 7 points and then 12.5 points overall with significance. And then for intervention and control, we have a very similar decline, and then again, similar with at 3 months follow-up. So we see in almost up until now that nutrition, education, should I say, intervention or counseling really helped those participants. So we also measured oxidized LDL, and that measures the oxidation of LDL particle. And not many studies have been conducted, or it's not routinely used, but it is anywhere, all the studies show that oxidized LDL, there's a strong association with cardiovascular risk and also cancers. So I wanted to use that and see how there might be a response to diet. Now, I won't put too much emphasis on the actual numbers, because from all my readings, the oxidized LDL, there's a challenge in measuring it. So different labs or maybe research studies are measuring it in a different way. So I wouldn't say, okay, this is very low because the normal range is 112 from the literature, but I want to emphasize the decrease also here. So we have a significant decrease from baseline to post-intervention and at follow-up, even more decline. We see a lot more decline here at control, but they started higher. So I don't know, but we have a huge range here. So some of them, what is worrisome, a lot of them have really high, not a lot, but there are people who had high also. But overall, we see a decline with the nutrition counseling. We measured HSCRP, and here we don't see major changes, but I wanted to point out a few areas. In the intervention, although it's not significant, we see some decline and then further here, whereas in the control, we see increase. So for the first time, we see group differences at follow-up between control and intervention, that they're significant. And I believe this is because control went up, intervention went down. That's where we see group differences at follow-up. As far as glucose management, hemoglobin A1C, again, for the total sample, we don't see significance. Also, we see kind of not a decline really, but more stagnant. But intervention, we see 0.1%. That is significant. At control, again, we don't see much of a change. And at follow-up, they went up again. And that's why we see a group difference here, because the intervention group decreased their HA1C at post-intervention. We also looked at those who have diabetes and versus those who don't have diabetes and those who get medication for that. And first of all, the sample size was quite small. 11 people were the ones who actually had diabetes and they were managing it. So we don't see any changes there, but the changes that we saw, which were very similar to these here, again, it's a sample size difference. It was for those who don't have diabetes already or pre-diabetes, that haven't been diagnosed with diabetes. This is very interesting. The omega-6 and omega-3 ratio in the blood, the fatty acids basically in the blood represent dietary intake. So looking at the Mediterranean diet score, which increased and basically more compliance to the Mediterranean dietary pattern, that somehow it's reflected here. And that's how I interpret it. So a ratio of 14 at baseline for everybody, that's a very high ratio, but it's not atypical. It's very common. This is exactly what it is in the literature for the Western dietary pattern. Basically, those the majority of people in this country and the West have this kind of ratio. Our ancestors and hundreds of years ago, and the recommended ratio is basically 2 to 1, in fact, 1:1. So we eat diets, we consume diets that they are very, very inflammatory. And omega-6 is an inflammatory fatty acid. It's very useful. We need all the fatty acids, but the ratio is what is actually contributes, or at least is associated with cardiovascular risk. So what we see here, I think, compliance with the Mediterranean dietary pattern. And although it was 14 in the intervention group, it went down by 2.71, which is, I think, it is quite remarkable. And then although lower difference, we see a 3-month follow-up, we see that difference. And in the control group, we have some decrease because they were actually having an intervention, I should say, counseling, but it went down to a lesser extent and then it went up. So this here is where we see group differences. And looking at when I looked at the individual fatty acids, that's due to decrease in omega-6, not the increase in omega-3. So decrease in the inflammatory component of the diet. The metabolic syndrome is being presented a little bit differently. So this is for the entire, for baseline actually, 53%, a little bit more, of the participants had metabolic syndrome, which is basically at least 3 of these components here. And this is primarily driven by waist circumference and some blood pressure. And then very similar, a little bit more the intervention, but no difference between the two. Now, as far as post-intervention and 3 months follow-up, this is for the entire sample. The way this table is presented is, for example, if at baseline they had no metabolic syndrome, at post-intervention about 3.4% developed metabolic syndrome, and those who had metabolic syndrome at baseline, 18 or 19%, at post-intervention, they didn't have metabolic syndrome. So basically the difference is that 15% of the participants did not have metabolic syndrome at post-intervention, and that change is statistically significant. At 3 months follow-up, so it's the same concept. When at baseline, they did not have metabolic syndrome, and at 3 months, they develop, and then those who had metabolic syndrome at 3 months, they didn't have metabolic syndrome. So the difference again is 50%. So basically, if we can kind of summarize this whole thing, 15% of the participants, they did not have metabolic syndrome, either a post-intervention or follow-up. Here is after the follow-up measurements, after basically the entire study ended, we gave them a satisfaction survey. So we wanted to see those who participated in the intervention arm, the Mediterranean dietary pattern arm, if they were satisfied and if there was an issue. So overall, there were 24 people. And so we asked them if they were satisfied with the program. 83% said that they were satisfied or very satisfied. If they watched the videos, 88% said yes. And 96% said that they would participate again, and 100%, which was very nice, said that they would recommend it to other World Trade Center health program participants. And also they were very satisfied with 96% of them with the physical activity tips, and they would like to see more cooking demonstrations in the future. And so one thing I did not mention at the beginning is we gave them incentives. And we, like the Fitbit, everybody got to keep their Fitbit, but also for the intervention group, because I wanted them to have a 3-liter can of extra virgin olive oil. And I got, that's the one I get, and it's from Greece. So I thought, okay, I need to get them started, because people usually either they don't know how to select it, or it's too expensive, they don't want to go out and do it. So I wanted to incentivize them and get them in the habit of using olive oil. So and of course we gave similar incentive like in monetary value to the control, so we are fair between the two. So apparently they liked it, and that motivated them to purchase more olive oil. I want to summarize the results, and we have a few slides about, manuscripts, etc., the outcomes. So there was high participant retention throughout the intervention and the program in general. So we thought the nutrition program was successful in improving the intake of the healthy foods, achieving its weight goals. It reduced PTSD symptoms. That it was a surprise, the level of reduction, and inflammatory biomarkers. If you remember, we also measured 10 cytokines. There was no significance there at all, and not much movement. So that's why I didn't put it, but I wanted to mention it here. Maybe those somehow are slower to being impacted, or it takes longer intervention or changes in order to see differences. So given the multiple comorbidities, including both physical and mental, and PTSD in particular, that the World Trade Center responders experience, we think these findings represent an important impact for the participants. But of course, we need a larger study to look at the mechanisms, how this work, or even if it's going to be, to validate the results in a bigger study. So after the study ended, and we received, and they continue receiving, the dietitians, more feedback from the participants, there were some changes or additions actually to the treatment in the clinics. They added the modified version of the Mediterranean diet questionnaire in their nutrition counseling with all the members. And they also are adding the 14-item questionnaire, the Mediterranean dietary score, to in the annual monitoring visit. And they are also comparing them to the other measures or the other tests, like the MOCA, PCL, and others. So, and their nutrition courses, they have been made available to everybody, that they are part of the health and wellness program. And also virtual wellness seminars are added to all the members. So there's a lot of adjustments and additions to the treatment of the members. So as far as our deliverables, or what we did to communicate our results to the world, we developed a manuscript that with all the information that I presented, and some more, and it's under review in the Obesity Journal. We presented in 2 conferences. I presented to the one that I always go on. I'm a very, very active member in the committees. Exactly those results, which was in Phoenix in past May. And also our dietitians presented similar findings in a poster at the Academy of Nutrition and Dietetics this past October. Those are the things that we did so far. What is in the pipeline is I sent an abstract and got approved for a poster for another conference that is very the Nutrition is Society of Behavioral Medicine, and which is going to be again in the same venue in Phoenix. And the other conference that I presented this past year, I also sent another abstract. But this time, we wanted to present the survey, the participant surveys, and with all the psychosocial, because we haven't, we collected a lot of data and we want to present all of them. And so that's where the focus is going to be. And we'll do a little more analysis and to write another paper on the survey, and then maybe comparing the dietary intake from those 3 different measures, like the chronometer, the DSQ, the NCI validated one, and the Mediterranean diet, and see how they compare because nobody else has done that in participants that have metabolic syndrome. They have all these cardiovascular risk issues and PTSD. So I think eventually having another grant for, to address comorbidity, because there's more trend going that direction to address maybe like both mental and physical health with dietary or more lifestyle interventions. Actually, that's the way to go, I think. So before I go, I'd like to thank, first of all, CDC NIOSH for this opportunity, which I think it was, without it, we couldn't really produce any of these results. And I think that really set the stage and benefited the World Trade Center responders. And also, I want to thank for all my co-investigators that helped me a lot in order to put this together and also really do the job, do the work. And I want to extend my huge gratitude to our two dietitians in the staff, that they are part of the World Trade Center staff, but also they were the study dietitians, because they are the ones who developed the materials. They are very, very creative, very motivated. So I want to thank that. And also everybody in the lab, where, because it was under COVID and there were a lot of restrictions, their hands were tied, but they all really helped to with phlebotomy and blood draws and blood pressure and other clinical measures that we collected. So they were interesting times, but because the intervention was designed, just happened to be designed to be done remotely, we didn't have to do major changes at all, actually, except doing the experiential learning remotely, and which was fun, but really it helped a lot to during COVID to have it designed this way. And I think that's the way to go. So that's what I had so far, and I think I'm going to, I don't see anybody, so I think I'm going to
Thank you so much for this amazing and informative presentation, Dr. Arcan.